Okay, very good morning, students. I think so. Previously we stopped, right? I'll just check the audio check. Is the audio clear? It's loud and clear. Is it loud and clear? I just want to know. Is it loud and clear? Okay, I think we stopped at. We finished GIT. Is it loud and clear? We finished GIT. Okay. So okay, we'll start fresh. We'll start with respiratory system. Respiratory system. Yeah, it can be respiratory system or respiratory system. You can call it anything, right? You can call it any phonetics you want. Okay. So we will start with a new chapter, that is respiratory system. So the first thing that we have to discuss is the generation. What is the generation in case of anatomical aspect of a respiratory system, right? So there is a classification regarding the anatomical aspect of airway. So Whipple's airway classification. Whipple's airway classification. So according to this classification, the whole respiratory system or the respiratory tract is divided into generations so that it becomes easier to identify a particular segment with the help of generation. So how many generations are there? Total 23 generations, right? So the first segment of the respiratory tract, that is trachea. The trachea is 0 generation. So it starts with a 0 generation. That signifies trachea. Trachea followed by bronchi. So bronchi becomes the first generation. So the first generation in the respiratory tract refers to bronchi. Bronchi follows bronchioles. Bronchi follows bronchioles. So bronchioles, they refer to the next generation, right? They refer to the next generation. Okay. So if you ask me bronchioles, right? So you take it up to terminal bronchioles, right? Terminal bronchioles. Terminal bronchioles refer to 16th generation. Terminal bronchioles refer to 16th generation. But if you ask me respiratory bronchioles, respiratory bronchioles, they refer to 17, 18 and 19th generation. Okay. Now bronchioles followed by alveolar ducts. Alveolar ducts. So these ducts refer for generation 20, 21, 22. Okay. You understand? Just 1 minute. Now the alveolar ducts finally ends with alveoli. So what is the generation of alveoli? Generation 23. So total 23 generations, right? So the bronchioles, they are the most segments which cover most of the generations, right? So the 0 generation signifies for trachea, first generation for bronchi, rest of the generations for bronchioles, and the terminal bronchioles signifies for the 16th generation, and respiratory bronchioles for the 17, 18 and 19th generation. Alveolar ducts, next 3 generations, that is 20, 21, 22, and alveoli for the 23rd generation. Okay, so that is all about generations, right? So regarding the anatomy of the lungs, everything we will discuss in anatomy. So where is the respiratory zone? In which generation the respiratory zone or exchange zone is located? It is located in from generation 17 to 23. That means it signifies from terminal bronchioles to alveoli. So the terminal bronchioles, respiratory bronchioles, alveolar ducts, alveoli, these all, they signify for the respiratory zones or exchange zones, right? Now if you ask me conduction zone, so what about conduction zone? Conduction zone signifies the zone or the segment in the respiratory tract where no gaseous exchange takes place, that is only gaseous storage occurs but no exchange occurs, right? So these can be equalized to or similarized to anatomical dead space. They signifies or they resemble to anatomical dead space. Now in which generation these segments are situated? These segments are situated in which generation? Can anyone? 0 to 16. Yeah, common sense, man. See, the respiratory exchange takes place from generation 17. Means the generations that are present before the 17th, that is from 0 to 16th, obviously they are just only conduction zone, that is storage zone, means no exchange will take place or otherwise determined as anatomical dead space. Now what is the volume of anatomical dead space? That is 150 ml. Remember, anatomical dead space total volume is 150 ml. Okay. Now conduction zone is from which segment to which segment? That is from trachea, which is which generation? 0 generation to terminal bronchiole. Terminal bronchiole. That is 16th generation. Right? You got it? So from trachea to terminal bronchiole, it is just only conduction zone, or otherwise no exchange takes place, or otherwise called anatomical dead space. What is the total volume? 150 ml. Okay. Understand or not? Okay. Now in this terminal bronchiole, you have to remember one thing. In this terminal bronchiole, you have maximum amount of smooth muscle. Maximum amount of smooth muscle. Okay. Now if the parasympathetic system is initiated, for example, I'll write here, parasympathetic system is initiated. Parasympathetic system is initiated, that is due to initiation of M2 receptors and histaminic receptors, that is H2 receptors. Then it leads to what happens? If parasympathetic activation occurs, what happens? Bronchoconstriction. Bronchoconstriction. So this is the main principle on which parasympathetic drugs causes the side effects. What is the most common side effect of parasympathetic? I mean, what is the side effect that you see if you use parasympathetic drugs? That is bronchoconstriction. That is a side effect. That is why parasympathomimetic drugs are contraindicated in asthma. Right? You understand? Okay. Now, if the sympathetic system is activated, that is beta 2, right? It leads to bronchodilation. Now this principle is used in which segments of pharmacology? Saba, Laba, Vilaba. What is SABA? Short acting beta adrenergics, long acting beta adrenergics, very long acting beta adrenergics. Short acting is salbutamol, terbutaline. Long acting is salmeterol, formoterol. Very long acting is alondetrol, pimbuterol, and pimbuterol. Very long acting beta adrenergics, right? But these very long acting beta adrenergics are used in COPD, chronic obstructive pulmonary disease. Long acting beta adrenergics are given in maintenance of asthma. right? And SNTs are given in asthma, intermittent or status asthmaticus also. Okay. Now, before getting into the derivatives of respiratory system, you should know one thing. What is that? Boyle's law. What is Boyle's law? Pressure is inversely proportional to volume. Get it? Pressure is inversely proportional to volume. This is helpful in determining some derivations, but now it is not needed. You just remember these things. Rest of all, just leave it off. Okay? Now, we will discuss something about the different respiratory movements that takes place in the respiratory tract. What is the most common respiratory movements that we observe? First one is inspiration. First one is inspiration, right? Is inspiration an active process or a passive process? Active process. Why? We are inspiring the air with effort. It is not going automatically. It is going only due to our effort. With which efforts? By using the muscles. Now, can you tell me which muscles? Active movement is applied due to action of which muscles? It's diaphragmatic muscle. Diaphragmatic muscle holds nearly 75% of the effort. It gives 75% of its effort. And external intercostal muscles, they supply 25% of total effort. Now, diaphragm shares 75% of the effort, and external intercostal muscles give 25% effort. So these two muscle groups help in active movement of the respiratory tract, so by causing inspiration. Now, what happens when inspiration occurs? There is expansion of thorax associated with increase in pressure of lungs. Increase in pressure of lungs. You understand? Increase in pressure of lungs. Now, what is the next movement that occurs instantaneously? Why I said instantaneously? Because it is a passive process. Because it doesn't need any support from muscles or anything. It's just a passive process. No muscles are needed. Okay? Then how it occurs? It is due to elastic recoil of lung, which is very important feature that a normal healthy lung should have. If this elastic recoil gets decreased or imbalanced, then it leads to some lung pathologies or difficulty in breathing. Right? Now, there is one more movement, that is forceful expiration. So, expiration itself is passive process. Then forceful expiration means you are putting some effort. In which conditions? Something like coughing. Coughing, can you do instantaneously? No, you should keep some effort. Your all bronchial muscles will give effort to cough out the sputum or the organisms which are irritating. Then shouting is also a form of expiration, etc. Right? It is an active process, and muscles are utilized, and use muscles which compress thorax and lungs. So what happens? Pressure gets increased and air is pushed out. Right? And air is pushed out. Now, we will discuss something about respiratory pressures. Okay. You have heard about a name called intrapulmonary pressure or intra-alveolar pressure. Also called IAP. Okay, so IAP. So see, listen carefully. Here you should keep your mind completely open. The intrapulmonary pressure or the intra-alveolar pressure is same as the atmospheric pressure. So it is equal. That's why if you just see, have you ever observed, if you just stand still normally, no air will go inside, no air will go outside. That means your lung pressures are completely balanced with the external atmospheric pressure. So that is the reason no air will go inside, no air will come outside. But if you do the same thing in space where there is no pressure, then obviously even if you don't breathe also, the pressures will get imbalanced, because the pressure outside the body, outside your body, is different from the pressure inside the body. See, on earth there is a pressure of 60 mm Hg in the atmosphere, which is equal to the lung pressure. So the lung pressure is also same. Now you may get a doubt like, sir, how lung pressure also appears same as like earth's atmospheric pressure? See, that is what evolution is. Evolution designed the organism like that. See, we were designed on earth, we were not designed on Mars, or we were not designed on Pluto, and those things were not sent to earth. We were itself designed on the earth. So we were completely evolved and adapted with these pressures. So we have our lung pressure 760 mm Hg, which equals the atmospheric pressure on earth. But if the same person goes into the space, is there any pressure in space? No. So what is the pressure in space? It is obviously negative, or at least no pressure. So what happens if you go there? Your lung pressure is more than this space. So automatically there will be an imbalance in pressure. So you can't even breathe correctly. Even if you want to stay still, you can't. So that is why the aircrafts, all the space satellites or the space station, the pressures are balanced manually. Remember, the pressure in the space station is maintained, right? The pressure in the space station is always maintained 24/7 by a mechanical way only or manual way only. So they have special machines for that. It will maintain the pressure in the space station. Okay, why? Because the outer space doesn't have any pressure, it is completely negative. So there will be a pressure imbalance that lead to implosion of the spaceship or explosion of the spaceship. So that is the main reason the pressure balance is very important when it comes to respiratory system. Now we will discuss on Earth only. We don't want to go to Interstellar or Gravity movie. We will discuss on Earth only. Okay. So wait, I'll clear this mess. See, you may think like, why Sir is explaining all this. See, if I explain this all component only, you can understand. Elsewhere it will be a blank for you. So the pressure in the atmosphere or the pressure in the lung is same as the atmosphere. For example, intra-alveolar pressure at rest is 760 mm Hg, which equals to atmospheric pressure, or you can also call it as 0 mm Hg when compared to Earth's atmospheric pressure, because both are same. So if both are nullified, it becomes 0. So 0 mm Hg difference. Which difference? The difference between the atmospheric pressure and the intra-alveolar pressure, there is zero difference, means both are equal, 760, 760. Now during inspiration, listen carefully, very very important. During inspiration, what happens is you inspire. You inspire means you are letting the air to enter your lungs forcefully by the action of muscles, that is diaphragm and external intercostal muscles. So during inspiration there is an increase of pressure. Where is there any increase or decrease? Is there increase or decrease? There will be decrease of pressure, not increase. There will be decrease of pressure. Why decrease of pressure? Listen carefully. I am just checking. Even previous thing also no one is telling that one. See, according to Boyle's law, pressure is inversely proportional to volume. So if the lungs get expand due to increase in volume, so that is why you should listen to the class carefully. What happens? There is an increase in volume, that implies during inspiration pressure gets decreased. So by deducing all this common sense, when you inspire, during inspiration air enters into the lung, so the pressure gets decreased to 759 mm Hg, or you can also 759 mm Hg, pull air to inside, or you can also say the difference is minus 1 mm Hg. Now during expiration, you are blowing out the pressure. You are just pushing the pressure out. That is also instantaneously. So your lung pressure increases. Okay, the difference is plus 1 mm Hg or 760 mm Hg. So it is, I will already discussed that expression is due to lung recoil and air gets pushed out. So this is all about the lung pressure explanation. Okay, you got it, everyone? Now we will discuss about another pressure, that is intrathoracic pressure. Intrathoracic pressure or pleural pressure. Intrathoracic pressure or pleural pressure. Now first you should get to know where is actually this pleural pressure is maintained. It is maintained in the pleural cavity. But what is meant by pleural cavity? Pleural cavity is a space which surrounds the lungs. I will write here, which surrounds the lungs. It is an empty space. It surrounds the lungs. And also one more thing is, it is suffused by two layers. What is that? Visceral pleura and parietal pleura. Right? So it has two layers. It is surrounded by lungs and it has two layers. Now most of the doctors are asking, sir, why the pleural space is important? So what is the real mechanics or dynamics behind it? See, now this is an important concept. You please focus here. Very very important. Even some of the PG students also don't know this concept perfectly. So that's why they make a lot of mistakes. So please, you don't do those mistakes. I am requesting you. So let us say like these are lungs. And I will just draw even more deeper line with. So this is lungs. And this is parietal. So this is parietal. And this is parietal. more space. But generally you don't see this much of space, but for explanation I am drawing. Okay. So now this one is called a pleural space. This is what a pleural space looks like. It surrounds the lungs and it is surrounded by parietal pleura and visceral pleura. Now what happens is, you know the rib cage, now the rib cage is surrounded like this. See, I'll draw here. Now the rib cage is surrounded like this. Okay. Now the rib cage is surrounded like this. So what this rib cage differs? Obviously this rib cage applies some pressure, on the lungs, right? So this is all rib cage. This is all rib cage. Now here, wait, I'll just draw it. This one, this layer is the parietal pleura. This is visceral pleura. Now this is all it is lung. This all thing it is lung. Okay. Now when the ribs are applying pressure on this layer, okay, on this layer, and the lung is applying pressure on this layer, so obviously the ribs apply pressure like this, the lungs apply pressure like this. See, the lungs apply pressure like this, ribs apply. So we'll draw even more neatly. So these are two layers. Here it is lung, here this is lung, here ribs are there. These are the ribs. Now ribs are applying pressure like this and lungs are applying pressure like this. So this space will be remain like this only. Okay. Now listen clearly. Listen clearly. Just 1 minute, wait. Okay, just back again. So what happens is, these two are the layers. This one is the lung, here the lung is there, now here the ribs. So what happens is, as the ribs are solid, they try to move outside because they are as firm as like this. They don't compress or they don't do like that. They will only expand, but they don't compress, right? They will expand and come to normal position, but they won't compress. And the lungs, they always try to recoil. So it is something like this, all component is space and these two layers are going in opposite direction. So obviously the pressure here gets decreased so much that it becomes negative. So there is negative space. Now for example, if someone tries and just cause you an injury with a chalk or with a knife, someone has just done a penetrated injury or penetrated wound, attacked on a person, and he has just pierced this knife into the lungs, right? And he again took back the knife outside. So what happens, this pleural space which is present here, see, I will mark it with red. This pleural space which is present here, as it is a negative pressure, so it is in the negative state, So when a piercing or a penetrating injury occurs and the object is taken out, so here in a tract or openness will occur with the outer atmosphere. As the outer atmosphere has a pressure of 760 mmHg, which is so much positive, the pressure which is present on the outside causes the outside air to enter into the pleural space quickly. So if the outer air enters into the pleural space quickly, as the lung has a feature of recoil, slowly the air which is entering into this pleural space starts to compress the lung. Further the lung compresses and finally the lung simply, what happened? Collapse. The lung gets collapsed. That's called lung collapse. If both lungs occur like that, or the lung collapse is also defined as atelectasis. Atelectasis occurs. Lung collapse. Now you understand? Or you want to tell me once again? Okay, some students are getting a question mark face, so I am telling once again. See, now I will draw neatly and I will explain. Don't ask me once more. This is the final time. I am joking. Even if you ask for another time, no problem, I will explain. Right? So these are trachea, bronchi, then you have lungs, then you have lungs, then you have pleura. So I will explain only on one side. You understand? Or why not? I will draw in both sides. Otherwise, so many students will fail. So this is pleural space. This is pleural space. Right? The space present between visceral pleura and parietal pleura. So this pleural space surrounds the lungs. So lung always, obviously, it wants to get recoil. And ribs, will they compress? No. Ribs always wants to expand. So these two things, the ribs and the lungs, they act in a different manner, opposite direction. So ribs go like this and lungs want to recoil like this. So this space always remains in a negative state. See, previously I will already discussed. So if there is any space where the pressure is negative, that means no pressure is present. Now if you try to keep an object which has some pressure, obviously the pressure gets moved, the pressure gets spread. For example, if you try to just stab the person, for example, a person has stabbed this person with a knife. A person has stabbed from the mid-axillary line into the, let's say something like 6th intercostal space, say something like here or here somewhere. So he went a stab and he just simply removed the knife after the stab. So here, this is the pleural space. So the space get exposed or it forms a communication with the outer atmosphere. But remember one thing, outer atmosphere is positive, pleural space is negative. So this positive pressure in the outer atmosphere causes the air in the atmosphere to get sucked or to get penetrated into the pleural space. Now, if this pleural space is filled with air or if it is continuously filling with air, so this air which is coming inside slowly compresses the lungs and the lung gets compressed to a final stage. That means this all area is filled with air. That led to compression of lungs, or otherwise called as lung collapse or atelectasis. Now this is all is air. This small one I will draw with a red color. This small one, it is lung. Okay, this is how you just get all sort of this condition. Now I think you now know very well how a pneumothorax is formed. So the thorax get filled with air. So here see, this is all air. It is filled with air. This is all filled with air. This is all thing. This is all air. So this is called pneumothorax. So in pneumothorax I write here, in pneumothorax the ITP or intrathoracic pressure, it either becomes 0 or plus positive lung collapse. Okay, positive lung collapse or pneumothorax occur. The ITP becomes 0 or positive. You got it? Right. Now we come to one more important topic, compliance, are also called stretchability. Compliance means stretchability. Now normal lungs are elastic and they show good coil and compliance. But remember, all lung parenchymal diseases show poor compliance. Why? All lung parenchymal diseases show poor compliance or poor stretchability. Can you tell me why? Because due to fibrosis, right? Due to fibrosis, inflammation, infiltration, etc., which is called as restrictive lung disease. Please wait on the line, please. Okay guys, so what is stretchability? Stretchability, compliance means stretchability. So in all lung parenchymal diseases, what we see is there is a poor lung compliance or there is poor stretchability. Why it occurs? Due to occurrence of fibrosis, inflammation, infiltration, etc. Now this condition where we see the poor lung compliance, the decrease in stretchability is called as restrictive lung diseases, right? Now some of the examples: asbestosis, silicosis, pneumoconiosis, sarcoidosis, etc. Now only disease with high lung compliance. Can anyone? High lung compliance, that is emphysema. Only disease with high lung compliance, that is emphysema. What happens in emphysema? There is loss of elastin protein. There is loss of elastin protein and low recoil right? So only disease with high compliance is high lung compliance is emphysema. Okay. Now, if the airways narrow with poor turbulent airflow, then that is called as, if the airways they get narrow with poor turbulent, laminar is like this, turbulent is like this. This is turbulent. Okay. So airway becomes narrow with poor turbulent airflow, then that is called as obstructive lung disease. The airway becomes narrow, and also the turbulence like airflow is seen, which is poor. Actually, poor turbulent airway is seen. That's called obstructive lung disease. You got it? So it's very simple. In obstructive lung disease, the airways become narrow. These airways become narrow. In restrictive lung disease, the problem relies in the lung parenchyma. That means the lung compliance or the stretchability decreases. Here the airway lumen circumference decreases or it becomes narrow. This is obstructive lung disease. This is restrictive lung disease. Okay. Now, compliance can be defined with a formula, that is delta V by delta P, where delta is actually the change, right? Where delta is actually the change. Now, normal lung compliance is 220 ml per centimeter H2O. 220 ml per centimeter H2O. Now, if the lung compliance decreases, that is, for example, if the lung compliance is given 100 ml per centimeter per H2O, that implies the lung compliance decreased, then it is a restrictive lung disease. If the lung compliance is increased, for example 300 is given in the question, then it is emphysema. Why? We already seen that the disease with maximum lung compliance, the high compliance is seen with the only disease, that is emphysema, right? But in obstructive lung diseases, what about obstructive lung diseases? We see normal lung compliance. Can you tell me why? Because the obstructive lung diseases, the main condition lies within the airways, not in the lungs, in the airways, that is the trachea, bronchi, everything. So they become narrow. For example, you take COPD, you take asthma, all these things. These all are obstructive lung diseases where there is normal lung compliance. You understand? Now we will discuss something about the surface tension, right? The surface tension of the lung. The surface tension, right? So, what is surface tension? Can anyone tell me what is surface tension? It is the inward force due to fluid and air inside alveoli. Now I will ask you one thing. If for example there is a paper and you just kept a drop of honey, what happens? This drop slowly moves like this and the paper gets moved to inside, towards the inside. Now if you keep nothing, it stays stable. If you keep water drop also, the water doesn't have that much viscous, so it simply moves. Now that is what a surface tension is, right? The inward force. Now if you take an alveoli, you take some liquid. Now this liquid, when it is just moving all along the wall due to surface tension, it pulls to inwards, pulls the alveoli inwards. This inward force due to fluid and air is called a surface tension. Now what happens is, surface tension will push air out. Surface tension will push air out, so that it may lead to alveolar collapse. Alveolar collapse. You understand? Now it leads to alveolar collapse or something called atelectasis. Alveolar collapse. Now for example, if there is an edema, pulmonary edema, what happens is, the fluid present in the lung, it pulls inside. So what happens? The air in the alveoli, they escape to outside, so it is completely filled with the fluid. What? The fluid plus fibrin, which makes a hyaline membrane. Now the fluid which is accumulated in the alveoli will pushes the air outside, thereby occupying the alveoli, which leads to all sort of complicatory symptoms, that leads to death of the patient, that is asphyxia, pulmonary apnea or asphyxia. So what happens? There is a decrease in compliance of the lung. Thus the lung will not stretch anymore efficiently, and the patient feels difficulty in breathing. So that is the condition, we call it as respiratory distress syndrome, where we also call it as hyaline membrane disease, right? So there is an accumulation of fluid plus fibrin makes a hyaline membrane, and there is a decrease in compliance and difficulty in breathing, leads to respiratory distress syndrome. So surface tension is reduced by a component called surfactant. They prevent the respiratory distress syndrome, pulmonary edema, all sort of things, and they prevent the collapse also. So this surface tension is reduced by surfactant. Surfactant is produced by type 2 pneumocytes. Okay, understand? Now we will discuss something about surfactants. Surfactants are produced by type 2 pneumocytes and Clara cells. Type 2 pneumocytes and Clara cells. Now these surfactants contain about 70% of phospholipids. Okay, and the main component is dipalmityl phosphatidylcholine, DPPC, dipalmityl phosphatidylcholine, DPPC, or you can also call it as lecithin. And minor component of surfactant is sphingomyelin. Okay. Now, what are the surfactant proteins? Or also shortcut you can call it as SP. There are 4 types of surfactant proteins: A, B, C, D, and the main one is B. This is the main surfactant protein. Now surfactant production is mainly observed in 18 to 20 weeks, starts by 18 to 20 weeks. Surfactant production starts by 18 to 20 weeks, but secretion and action occurs at 28 weeks, and the maximum secretion as well as the lung maturity occurs in which week? Can anyone? 34 to 35 weeks. But if you ask me perfectly, it is 34 weeks. That is why if there is a preterm pregnancy, or if there is a complication where we should terminate the pregnancy, we will just make sure we will drag the pregnancy on or up to 34 weeks. For example, she is getting a complication at 32 weeks. So slowly we will check one by one week. So we will bring up to 34 weeks. At 34 weeks we will give steroids. What does steroids do? They cause lung maturity. They give the final boost to lung maturity. Then if you want, you can go for any emergency procedure, not a big problem. You should give steroids. Okay. Now that is the condition called preterm steroid therapy. What is the steroid given? Generally it is dexamethasone. How many doses? 2 doses. Generally previously it is to give 1, and with a gap of 12 hours second shot is given, but right now 2 doses are given at a single shot. I think it is a recent update given in some publications, but you don't forget all about this. Only thing you remember is lung maturity occurs at 34 to 35, where if in the case of a preterm you give dexamethasone therapy. Okay. Now pulmonary function tests, PFT. With what device you do it? Spirometry. Pulmonary function test with spirometry. Now, what is the normal inspiratory volume and expiratory volume? Normal inspiratory and expiratory volume. It can be easily taken into tidal volume, which is 500 ml. Right? Now if you ask me maximum forceful inspiration which is above TV, that is tidal volume, that is called inspiratory reserve volume. How much? 3 liters, which is above TV, tidal volume. Now maximum forceful expiration after normal expiration, that is expiratory reserve volume. How much? 1.3 liters. Now air left in the lungs after maximum forceful expiration. Air left in lungs after maximal forceful expiration. How much? That is residual volume. That is called residual volume, and it is 1.2 liters. You got it? You got it or not? You got it or not? Right? So maximum forceful inspiration above tidal volume is called inspiratory reserve volume, which is 3 liters. Maximum forceful expiration after normal inspiration, after doing a normal inspiration, if you still forcefully expire some air, then it is called expiratory reserve volume, which is 1.3 liters. Now the air left in lungs after maximal forceful expiration, that is called residual volume, that is 1.2 liters. Now someone is asking, sir, can you just define this thing on a graph? Yeah, sure, why not? We'll just define this on a graph. Okay, wait, I'll just tell it. Now if you ask me, since residual volume stays in the lungs, it won't come outside. Residual volume, it won't come outside. Remember, it won't come outside. Why it will come outside? It stays in the lung, it won't come outside. So that is why residual volume, it's not shown on spirometry. The reason why residual volume is not shown on spirometry is it won't come outside, it stays there, right? Why it should stay there? Why residual volume should be present in the lung? Why some part of the volume of air should always stay in the alveoli? Because to prevent collapse. If that part of air also, if it comes out, then the pressure will become negative. Ultimately that leads to alveolar collapse. To prevent that, there will always be a residual volume, right? Now what is capacity? You heard about different capacities, tidal capacities, all these things. It is actually the sum of two volumes. Simply remember, the sum of two volumes is called a capacity. For example, if you ask me inspiratory capacity, it is tidal volume plus inspiratory reserve volume, that is equal to how much? It will be something like from 3.5 to 4 liters. Now if you ask me expiratory capacity, that is something from tidal volume plus ERV, expiratory reserve volume, that is measuring something from 1.8 to 2.0 liters, that is 2 liters, 4 liters this time. Okay. Now what is FRC, functional residual capacity? It is expiratory reserve volume plus residual volume, expiratory reserve volume plus residual volume, that is equal to how much? Can anyone? .5 liters. Simple, man. 2.5 liters. What is the normal residual volume? Anyone? Residual volume normal value is 1.2 liters. It stays in the lung, it won't come outside. Now functional residual capacity is expiratory reserve volume plus residual volume, 2.5 liters. Now it is the air left in the lungs after normal expiration or at rest. It is the air left in the lungs after normal expiration or at rest. Now as ERV, by this statement you have understood, ERV doesn't come out. As ERV doesn't come out, right? As ERV doesn't come out and stays within the lungs with RV, that is residual volume, it is sum of both ERV plus RV. So spirometer doesn't give values of RV and FRC, functional residual capacity, because ERV doesn't come out, residual volume doesn't come out, so if ERV and residual volume doesn't come out, then FRC cannot be determined, because FRC is equal to sum of ERV, essential expirational residual volume plus residual volume. So expiration reserve volume plus residual volume, if both of these don't come out, then obviously in FRC also will not come out. So FRC cannot be defined in a spirometry. RV also cannot be defined in a spirometry. So RV and FRC cannot be defined in a spirometry. Now you got the answer. Okay. Now we will just talk about now we will just talk about FRC estimation. So we will just discuss about force residual capacity, functional residual capacity estimation. So there are some methods by which we can do this. One is helium dilution method. And another one is single breath. Guys, remember this is very important. I think in NEET PG 2021 this question came, so just focus on this topic. Single breath nitrogen washout. Very important topic, guys, please focus on it. Single breath nitrogen washout. Now there is one more name for it, you just remember this, it is also called Fowler's method. Now one important thing is it gives the value of dead space also. Okay, gives dead space also. Now there is one more mechanism, that is one more procedure, that is plethysmography. Okay, plethysmography, which is done in obstructive lung disease. Okay, now we can discuss about one more important component, that is vital capacity. What is vital capacity? It is the maximum inspiration followed by maximum expiration. Maximum inspiration followed by maximum expiration. Now normal vital capacity in males, it is how much, can anyone? 4.8 liters. Now if it is in case of females, it is 3.2 liters. Now this is the normal vital capacity in males and normal vital capacity in females. Okay, females it is 3.2 liters. Okay, remember these two values. Now we have one more value, that is total lung capacity. What is total lung capacity? Total lung capacity, it is the sum or addition of all four volumes. What are those four volumes? Can anyone? Now TLC or total lung capacity is equal to IRV plus ERV plus TV, tidal volume plus residual volume, that is equal to how much? Normal 6 liters. So this is the lung capacity, 6 liters. Now, general spirometry fails to give which measurements fails to give residual volume, expiratory reserve volume, and one more thing is which one? Residual volume, expiratory reserve volume, and total lung capacity. Right? Now, this residual volume and ERV combine to form, we call it as functional residual capacity. So FRC also we cannot get from spiro. Okay, fail to give functional residual capacity. Now, in total lung capacity, we can calculate by vital capacity plus residual volume. Vital capacity plus residual volume, or you can also calculate by inspiratory capacity plus functional residual capacity. Now we will discuss the graph. Okay, the graph, which is very important. I think most of the doctors are waiting for this graph. Don't worry guys, I already came, I am there. Just 2 minutes, we will draw the graph as fast as we can. Okay, don't think like why R is doing everything right now. See, don't think like that. See, this is also some sort of time pass. Maybe you might get boring. So if you see someone drawing something, ultimately your mind gets attentive towards it. Your mind gets some sort of preliminary attentive, right? So I think I will draw here one more. I think the board will not be sufficient, but still we will try to adjust it. Any new movies? Anyone? Did anyone see any new movies? Please comment it down in the comment section. Anyone seeing new movies? How are they? Are they okay? Are they fine? I just want to know. See. Okay. So we will just draw one line like this. I think we should draw here. Keep it here, and we will keep it one more thing here. Okay. Now okay, so we'll draw like this, one more thing, right? Now we'll draw like this, one more line. Okay, now the so-called the respiratory rhythm or the graph move like this. Okay, don't feel pity, my drawing is not good, I know that. Okay, now simply speaking, wait, I use different color. This one is vital capacity. Okay. This one is vital capacity. I'll write here vital capacity. This is vital capacity. Now this one is tidal volume. This one is tidal volume. Okay. Now this one is inspiratory reserve volume. This one is inspiratory reserve volume, right? Because it is the maximum forceful inspiration. See, normally it occurs here up to this mark, but he is inspiring forcefully. Maximum inspiration forcefully is done. So this is inspiratory reserve volume, and this is expiratory reserve volume. This is expired forcefully. So this is expiratory reserve volume. Okay. Now this one is called functional residual capacity. Functional residual capacity, and this one is called residual volume. This one is called residual volume. You understand? This one is called residual volume. Okay. Now if you take in spite of spaces, right, take here, sorry, take up to here, right, this is inspiratory capacity. This is inspiratory capacity or IC, inspiratory capacity or IC. Okay. Now this is expiratory reserve volume. This is expiratory reserve volume. Okay. This is expiratory reserve volume. This is residual volume. This is residual volume. Now this whole component we already determined that it is called vital capacity. It is called vital capacity. This is very important, vital capacity. And this one we already know it is residual volume. Okay. Now this is called inspiratory reserve volume. This is inspiratory reserve volume, IRV. Inspiratory reserve volume. Now this is tidal volume. So we are talking about volumes, tidal volumes. Then this is functional residual capacity. Functional residual capacity. And here in the final column we say it as total lung capacity. Okay, understand? Everyone understood, right? I think with the help of definitions you can easily simplify it. It's not a big problem either for you or for anyone. It's not a big problem at all. Okay, so I think we finished everything. So we will discuss some of the pulmonary function. I will just keep it. We will discuss some of the pulmonary function tests in different diseases. Okay, pulmonary function tests in diseases. Please wait 1 minute. Wait 1 minute. So we will discuss pulmonary function test in diseases. So for example, if we take RLD, that is restrictive lung diseases, what happens is there will be low vital capacity. There will be low vital capacity. Why? Because due to decreased compliance, and all volumes are decreased. All volumes are decreased, or you can say less. Now if you take OLD, that is obstructive lung diseases, what happens in obstructive lung diseases? We already discussed, that is there is a decrease in, the respiratory flow, the conduction in the respiratory tubes, there will be a normal vital capacity, because the parenchyma, the lung parenchyma doesn't show anything, exclusively, but the conductive thing, the conductive system gets decreased. So there will be low vital capacity due to air traps in the conductive system or in the component system itself. So there will be a normal vital capacity or low vital capacity, normal vital capacity or low vital capacity due to air trapping. But in RLD there will be low vital capacity, because RLD itself defines that there is a decrease in lung compliance. But in old, that is obstructive lung diseases, there will be normal vital capacity or low vital capacity due to air trapping, right? Now you take TVC, total TVC by FVC, right? So it's called as timed or forced vital capacity. So what it does, divide TVC into FE V1, FE V2, FE V3. Now what is this time forced vital capacity? Now time forced vital capacity means something which defines after a period of after a period of time. For example, FeV1 denotes forced expiratory volume in the first minute. One defines the first minute or in the first second, forced expiratory volume in the first second. So FeV1 denotes forced expiratory volume, volume in first second, that is called FeV1, right? What happens is, it is a part of vital capacity expired in the first second. It's a part of vital capacity expired in the first second, right? So you can call it as 4 liters out of 5 liters, right? So the 80% is, if it is expired in the first second, then it is normal. See, for example, see guys, see, don't confuse, I will just make it normal. 5 liters of air is there. So in the first second you expired 4 liters, that implies 80% of the total volume. So expiring 80% is actually normal. So the normal thing that should be present is 80% should be expelled in the first second, expired in the first second, means if it is total capacity is 5 liters, then 4 liters should be expired in the first second, then it is normal. Okay, so you can define it like normal FeV1 is 80% of timed vital capacity, or you can also say like 0.8. Now if what is meant by low FeV1, how you can count it like low FeV1? If it is less than 80% of total vital capacity, for example time vital capacity. Now where it will be in less than 80%, then it will be in obstructive lung diseases, where the forced expiratory volume decreases, which is less than 80%, right? Why? What happened? Because due to narrow airway. Okay, so that happens. Now if you ask me, the normal FeV1 percentage, if it is greater than or equal to 80%, then it occurs in respiratory lung diseases. So these two things, please you just remember these 3 statements. Okay, normal FeV1 is 80% of the timed vital capacity. Now if there is a low FeV1 less than 80%, it is seen in obstructive lung diseases. Why? Due to narrow airway, that is problem is in the conductive system. Now if the FeV1 is normal, that is either greater than or equal to 80%, it is seen in RLD, or it can be taken as RLD. In RLD, generally FeV1 can be normal or it is greater than 80%. Okay. Now if you ask me what is the best investigation to differentiate RLD and OLD, that is OLD, then it's obviously FeV1. Right. Now what is peak expiratory flow rate, PEFR? You just remember that rate, the flow rate, that is 250 to 500 liters per minute. Now if you ask me mild expiratory flow rate, MEFR, then it will be something like 150 to 300, 150, this is 5, don't confuse, this is 5, 150 to 300 liters per minute. This is the mid expiratory flow rate. Peak expiratory flow rate is 500 liters per minute and mid expiratory flow rate is 300 liters per minute. Okay, everyone? Why someone is getting doubt? How this expiratory flow rate? See, guys, it is very simple, guys. Why someone is asking, sir, how expiratory flow rate this much? Someone is asking this question. Sir, expiration, how you got 300 liters per minute? Why? It's a simple calculation, man. Okay, I will tell it in the next class. Okay, it's a simple calculation. See, it's just a simple calculation. I'll tell it in the next class, right? Because right now we are lagging behind and we should complete it as fast as we can. Okay. So revision, but okay, I will take a class. I will just explain in the next class. Okay, don't panic. So just note it down in the comment section. I will write, right? So previously one doctor asked me, sir, please explain the cardiac muscle cell potential once again. So I explained it. So another doctor asked another topic. I explained it again. So if you have a doubt, you just ask me. I will explain it. Okay? Don't panic, right? What is ventilation, right? What is ventilation? It can be denoted with a name, that is pulmonary ventilation or minute ventilation. It is the air which goes in and out per minute. That is called pulmonary ventilation. That is tidal volume into respiratory rate. That is equal to 12 to 16 breaths per minute is the wait. So what is the respiratory rate normally? It is 12 to 16 breaths per minute. Right or wrong? Right. Now what is the tidal volume? That's 500 ml into how much is the respiratory rate? 12, that is 6 liters. So this is the ventilation. This is the minute ventilation or pulmonary ventilation. Now if you ask me alveolar ventilation. Now air getting exchanged per minute. It is air getting exchanged per minute in lungs. That is called alveolar ventilation. Now AV is equal to tidal volume minus dead space into RR. That is equal to why air getting exchanged in alveolar volume? Why air in and out in pulmonary ventilation? Why one doctor is asking. See, alveolar ventilation is something which includes only the region where the air gets exchanged. Exchanged is different from air getting in and out. See, if for example you are there, you are a doctor. For example, there is a person, say something like his name is Ramu. Ramu dated with 5 girls and he married one girl. Her name is, say something like Visalakshi. Now if you ask me, how many girls did Ramu marry? Will you say 5 or 1? You will say 1. But if you ask him, how many girls did Ramu dated? You say 5, because he dated 5 members, in which 1 member he married. 4 members, they were thrown away. They were get out. So that is the difference. So here, how many members did Ramu dated? How many members with how many members did he dated? That is taken as pulmonary ventilation or minute ventilation. The total members that were dated. How many girls were dated? 5. Here, how much air is entering in and out? 6 liters. Now, how many members with how many members did he undergo marriage? How many girls did he marry? 1 girl, that is Visalakshi. That is taken as alveolar ventilation. That means the air which is getting exchanged, or which it is getting participated in air exchange. Okay, he dated 5 girls, but he is having lifelong fun only with 1 girl, right? So here, so much of air is coming inside lung and going out, but only some portion of the air is only being exchanged. Rest of the air is stuck in the dead space. So we do not include dead space in alveolar ventilation. So we do not include other 4 dated girls in the marriage. Only the 1 girl with whom he had married and he had nice first night, only that girl is included in the alveolar ventilation. Okay, you got my question? You got my answer. So dead space is air not getting into, is the air where the air is not getting in the participation of exchangement. So in exchange, in airway and alveoli. So if you take the anatomical dead space, how much it is? Normal 150 ml. Previously we already studied. Now if you ask me alveolar dead space, what is the alveolar dead space? Normal, it is 0 ml. It is 0 ml. Because why? Arey bachcho, all the air in the alveoli can be exchanged na. All the air in the alveoli can be exchanged. See, for example, if Ramu has married 2 girls, total how many girls did he dated? 5 girls. This is minute ventilation. These 5 girls are minute ventilation. How many girls did he marry? 2 girls, right? So this is alveolar ventilation. Now if Ramu married 2 girls, will he have first night with 2 of them or only 1 of them? Obviously he will have first night with 1 of them. Monday 1 girl, Tuesday 1 girl, Wednesday 1 girl, Thursday 1 girl. So obviously he will have first night with 1 of them. Will Ramu say, no, I will have first night with only this girl, I don't want? Will he say like that? No. Who will deny a laddu if he is offered with 2 laddus? Will he ask only, no, I only want 1 laddu? Will he say that one? No. He will take 2 laddus. Both the laddus he will take. So in this condition also Ramu will have fun with both the women. That means either he will have like Monday 1 girl, Tuesday 1 girl, Wednesday 1 wife, Thursday 1 wife. So like that both of the wives will be having fun with Ramu. So in alveoli also there will not be any dead space. Why? Because all of the air will be participating in the exchangement. Now if you ask me physiological dead space, now this is important. Leave about Ramu and his wives, he is very busy with them. We will think about physiological dead space. Okay, logical dead space. Okay, if you think about physiological dead space, it is the anatomical dead space plus alveolar dead space. This is the total physiological dead space. Anatomical dead space is 150. Alveolar is 0. That means 150 ml is the physiological dead space. Okay. Now Previously we deduced a formula. What is the alveolar ventilation? Total volume minus dead space, tidal volume minus dead space into respiratory rate. So tidal volume 500 minus dead space 150 into respiratory rate 16. That comes to how much? We took 12 now. Respiratory rate we took 12. So ultimately we will keep 12 here. So how much it will be coming? It will be coming like 4.2 liters per minute. Now this is the alveolar ventilation. So remember one thing, pulmonary ventilation or minute ventilation is 6 liters. Alveolar ventilation is 4.2 liters. Okay, clear? Now we will discuss something about ventilation perfusion ratio, VQ ratio, ventilation perfusion. No, don't be like Ramu. See, having a journey with one wife is only like walking in a desert with no drop of water at least. But if you have two wives, it will be like I can't say how that emotion will be. Only emotions only, no emotion. Okay. Don't be like Ramu. You be like Ramu in the phase 1, no problem, dating. But don't go to phase 2, that is marriage. Be like a Rama only. Don't be like Ramu. Okay. Have one wife, that is okay, fine. Then no need to fight with multiple knives. Okay. Now what is ventilation perfusion ratio? This ventilation perfusion ratio actually indicates the gaseous exchange. What sort of gaseous exchange is being occurred? Okay, so that is represented by V by Q, that is air coming per minute by blood coming per minute. You understand or not? You understand or not? Say one thing. Did not. Okay. This is alveoli, this is capillary. Okay. Now how much air is coming to here, this alveolar base, to the surface, and how much blood is coming or flowing through the, how much blood is flowing through the capillary. Now this difference, how much air coming by how much blood flowing in the capillary, that is called VQ ratio. Why this should know? For example, X amount of volume of air comes here and Y amount of volume of blood comes here. How much amount of X is being exchanged with the Y volume of blood, that indicates the ventilation perfusion ratio. Now you understand now? That is ventilation perfusion ratio. Now for example, the ideal VQ ratio is, ideal I am speaking, right? Ideal VQ ratio is 1. Okay, so that implies it indicates the best exchange. But if the VQ is not equal to 1, right? Now this is called as VQ mismatch or poor exchange. Which where you can see in hypoxic state. Now if the VQ is more than 1, right, means the air coming to the surface of alveoli is more than the blood flowing through the capillary. Where you will see, that implies much of the air is left unexchanged. So it comes to alveoli and it and it goes back same like that only. It is not exchanging with the blood, right? So it is an increase in, it implies there is an increase in a physiological dead space. There is an increase in physiological dead space. You understood or not? Or you want me to tell in a different example? Okay, I will tell you an example. See, it's all about fun, man. See, we were discussing since the previous, I think 1.5 hours. Maybe you might have been burned out, right? So, see, there is Ramu. Once again, Ramu. 2 wives. Okay. one wife each day. So one wife Monday, one wife Tuesday. So it is 1:1 ratio. Okay, it is equal and it is perfectly matched. But if it is always this wife Visalakshi only having fun with Ramu, but with this wife Ramalakshi, she is not having any fun. So there is a VQ mismatch. There is a VQ mismatch. So obviously there is a VQ mismatch. So this is seen in hypoxia. Now, for example, what we discussed, we said one wife a day. If this for Monday this wife, then Tuesday this wife, then Thursday this wife, then Wednesday this wife, then Friday this wife, Thursday this wife. So we kept a rule like one wife one day. But if both the wives came to the bedroom for the war with only single person Ramu, now is it possible? Can Ramu fight with both the people? If Ramu is extremely efficient, he can, but he is very lean and is like a very pathetic guy. Now can he manage the both wives? No. Now will they be satisfied? No, they will not be satisfied. So most of the air is left unchanged. So most of the wives get unsatisfied, they are not yet satisfied. So the most of the air gets left unchanged. If only each wife comes each day, then they will get satisfied. But both the wives comes at a single day, then they will be unsatisfied. So you got this point. So if more air comes, then more air comes more than the blood, more air comes than the blood reaching the capillary, then obviously it leads to VQ greater than 1. So that implies it is seen in increased physiological dead space. Okay. Example, if you want me to give example, I will tell you. Pulmonary embolism, emphysema. Okay. What happens in embolism? Due to emboli, there will be a decreased or obstruction to the blood supply. So there will be a decrease or obstruction to the blood supply. In emphysema, we already discussed maximum compliance is seen in only disease emphysema. So there will be an increased air flow. So both of them cause VQ greater than 1 because due to there is an increase in physiological dead space. Guys, these are very important, guys. Please, I am requesting you, I am begging you, please study these topics as perfect as you can because these are very important. You get mostly INICT clinical scenarios depending on these topics only. Don't think like from different or very crucial or very complicated topics the questions will be given. No, INICT is very simple exam. The only thing is the clinical scenario should be correlated with the concepts. Now the VQ I have told now, this VQ mismatch they will give with a patient of 48 years came with a complaint of pulmonary embolism. So the VQ ratio will be mostly absorbed. How much of VQ ratio will be seen? Is it more than 1, equal to 1, less than 1 or none of this? So it will be more than 1 because due to increase in physiological dead space. See, INICT will be this simple, but the only thing is you have to correlate the concept with the clinical scenario. As simple as that. Right? Don't mess it up, man. Hypoxia. See, I am explaining this much friendly. So you just please revise the concept. Don't get tense. I am here to clear all your doubts. Generally seen in all lung diseases. Okay, and high altitudes, right? Then if there is in VQ mismatch conditions, etc. Now what happens here is hypoxia, the tissue gets less oxygen because as the lungs fail to oxygenate the blood, so the tissue gets less oxygen, so there is a decrease in PaO2 and SpO2, partial pressure of oxygen. And one more thing is you can observe central cyanosis. What is central cyanosis? What is peripheral cyanosis? Central cyanosis is the bluish discoloration seen at the membranes of the body. Peripheral cyanosis means at the limbs. This all comes under peripheral cyanosis. Palms, all this. Tongue, mucous membranes, tip of the nose, everything comes with central cyanosis. Okay. Now if it is anemic hypoxia, if it is case of anemic hypoxia, what you will see? There will be no cyanosis. Right? And there will be decreased or less hemoglobin. If it is stagnant or ischemic hypoxia, ischemic means decreased or terminated blood supply. Ischemic hypoxia, less blood flow to the tissue, generally seen in shock, Buerger's syndrome, then etc. some other conditions. What is histotoxic hypoxia? Now this is important. Histotoxic hypoxia. What is this? The tissue fails to use the oxygen despite normal blood oxygen concentration. So this is very important. Histotoxic hypoxia is something, the problem lies with the tissue itself, so that the tissue fails to use sufficient amount of oxygen even though the blood having sufficient amount of oxygen concentration, but still the tissue fails to utilize the oxygen. For example, you can see in conditions like cyanide toxicity. Why? The cyanide binds with hemoglobin, forms cyanoglobulinemia. So what happens? The cyanide component binds with the hemoglobin, thereby leading to preventing it from binding to oxygen. Right? And this cyanide inhibit what? Wait, I'll clear it up. This cyanide inhibit the complex 4 of electron transport chain, reason which causes histotoxic hypoxia. Now if you ask me what is the normal VQ ratio of whole lung, then it will be something like 0.8. Okay. You may ask like, sir, you said ideal. See, I am telling about ideal previously. This one is normal VQ ratio of whole lung. But if you ask me apex of the lung VQ ratio, then it is 1.3. Why it is maximum at the apex? Due to poor perfusion. Perfusion means supply of blood supply is less, so that is poor perfusion, so the VQ is more at apex. Now physiological dead space present, and one more thing is maximum partial pressure of oxygen at apex. Okay, now this is the reason, right? This is the reason, due to presence of maximum oxygen concentration at the apex, it is the most favorite site for TB, which is called, what is that name? Anyone? Gons focus. Gons focus. Very, very important. Okay, right? So why apex is having VQ ratio more than 1? Because due to poor perfusion. Because the physiological dead space is present as well as maximum oxygen concentration is at the apex, which makes it favorable for the TB. That's called Ghon's force. Now if you ask me, what is the base of lung VQ ratio? Base VQ ratio, it will be something like 0.6, right? Why it is minimum? Due to maximum perfusion. Due to maximum perfusion, right? Here poor perfusion in apex, so it is maximum VQ. Here that is minimum VQ. Why? Because maximum perfusion means more amount of blood supply going towards the base of the lung. Why maximum perfusion at base? One of the factor is gravity. Gravity leads to maximum perfusion to the base of lung. You got it? Got it. And one more thing is, even there is maximum ventilation at base due to maximum space. Okay? Maximum space. Okay. Now we will discuss something about partial pressure and gases exchange. Okay. Just 1 minute. Wait, I'll just take some rest. 1 minute. I'll just check something and I'll come, right?
Welcome to Common Electronic.
वाचताना